intervention in the first year of life.
Sorry, Dr. Hussein, can you go to the first slide, please? Because we just started recording. All this lecture will be shared in the YouTube later on. Okay.
Okay. So our lecture will be about critical congenital heart disease. First, we start by definition. As you know, this critical congenital heart disease is defined as a structural malformation of the heart that are present at birth and require intervention in the first year of life. So neonate with this cardiac disease might present in acute or critical condition. And this patient, they need intervention in first hour of life. So it is very important to know about this critical congenital heart disease. These diseases are not common among general pediatric emergencies, as you know, the cardiac disease, but it is highly important to recognize an early treatment to be initiated for this heart disease. Because late diagnosis can cause significant morbidity and mortality for this patient. Incidence is varied. You will find a lot of information about this incidence, but in general, the incidence is reported about 7 to 9 per 1,000 live births. And 1/4 of these cases is a critical congenital heart disease. So the etiology is, generally speaking, in pediatric cardiology, the etiology of cyanotic congenital heart disease or in cardiac disease in general is unknown. There is some genetic and environmental factors that contribute to this condition. As mentioned by Dr. Bashir, there is congenital heart disease is isolated sometimes with some syndromes, like Down syndrome, which is mentioned by Dr. Bashir, associated with AVSD, Turner syndrome, scarication, non-alagile, which is associated with HOCM and pulmonary artery disease, Digeorge syndrome, which is associated with conotruncal anomalies and interrupted aortic arch. Also, we have to know that diabetes also is associated with some types of congenital heart disease like TGA, VSD, and septal hypertrophy. Dr. Bashir already spoke about fetal circulation, so I'm not going to go in detail of this, but important to know that placenta is the main oxygenator in the fetal circulation, and there is 3 main area of shunt which is necessary for survival in the neonatal circulation. One of these is ductus venosus. The other one is ASD and BDA. So after the fetal circulation, it comes a transitional circulation when the first few breast lungs are expanded and the placenta serve as, the lung now serve as oxygenator instead of the placenta. Then the foramen ovale functionally closed when the left atrial pressure increased, followed by the closure of the BDA, which is occur in the first hour of life. And sometimes the BDA will persist, as mentioned by Dr. Bashir, and sometimes it is necessary for life in critical congenital heart disease. Now we come to the neonatal circulation when the ducts close, the foramen ovale closed. Now the RV is connected to the pulmonary artery, the left ventricle connected to the aorta. There is normal valve, as mentioned by Dr. Bashir. The saturation in the right side of the heart, almost 75, while the left side saturation is 100. And it's important to know that the pressure in the right side is almost 1/4 of the left side. This is very important because when we have a shunt like VSD, Usually the shunt will be from left to right in the first few days or few weeks of life. The pulmonary vascular resistance is high. So we need to know that after 6 weeks, each patient might show the symptoms of either critical or non-cyanotic congenital heart disease. So very important to know about newborn screening, which is done in the first 24 to 48 years of life. This is important to check all babies to identify those with critical congenital heart disease. Usually this CCHD screening is done for, as mentioned, for the baby in the first 24 to 48 years of life. And we have two categories: those who fail the screen and they need to be screened by either chest X-ray, echo, and those who pass the screen. Any patient with saturation above 95%, and there is no difference between the upper and lower limb saturation, these patients are past the screen and no need to do anything from the cardiology side. For those patients who have saturation less than 90, oxygen saturation by pulse oximetry is detected to be less than 90%, or they have a difference in the saturation, or even they have a borderline saturation between 90, 95, and there is a difference between the upper and lower limb saturation. These patients need to be seen by cardiologists and need to be screened. Why we screen these patients? Because we need to target these diseases. This is a very critical diseases and can lead to significant morbidity and mortality in the first few hours of life. And sometimes might present late, and we need to detect them early so as to be tackled and treated early. Dr. Bashir mentioned some of these, and I'm going to speak about the others. What is the clinical presentation of critical congenital heart disease? These diseases might present with either cyanosis or congestive heart failure or severe hypotension. For those who present with severe hypotension, shock and collapse, like coarctation, hypoplastic left heart syndrome, critical aortic stenosis, those will present with cyanosis is the right side heart lesion, like severe tetralogy of Fallot, pulmonary atresia, and sometimes they may present with cyanosis and congestive heart failure, like truncus arteriosus or even hypoplastic left syndrome. Okay. From this critical congenital heart disease, we define them as ductal dependent. These ductal dependent are mainly categorized into either pulmonary duct dependent or systemic duct dependent. What do we mean by ductal dependent? That the ductal dependent lesion is that lesion which is like a severe hypoplastic left heart, right or left heart, and this lesion depend on the patent ductus arteriosus. They cannot tolerate the transition from the fetal to postnatal serial circulation after birth, and these lesions, they depend on the duct. And we need the duct for this lesion. If we face this critical congenital heart disease, we have to start prostaglandin to keep the patent ductus arteriosus patent, or to keep it patent for survival of these children. These ductal dependent are categorized in 2 or sometimes 3. I'm going to speak about first about the pulmonary duct dependent and systemic duct dependent. What do we mean? We mean by pulmonary duct dependent? Pulmonary blood flow for oxygenation is supplied by systemic circulation via PDA. It means that if we have like obstruction in the right side, like critical pulmonary stenosis or severe type of tetralogy of Fallot, these patients cannot survive if we don't have a duct that supplies the pulmonary blood flow from the aorta to the systemic. So we need aortopulmonary shunt like a BDA to keep this patient alive. Regarding the systemic ductal dependent lesion like hypoplastic, aortic stenosis and coarctation and interrupted aortic arch, this patient also need the duct to survive. As we mentioned, they can present with severe cyanosis or shock or collapse. This is one of the ductal dependent pulmonary circulation is a critical pulmonary stenosis. And as you see in this diagram or this illustration, here this patient has severe aortic stenosis. So the pulmonary blood flow is sluggish. So, and they have almost always they have a right to left shunt. So the blood goes from the right atrium to the left atrium and causing cyanosis. And this patient, they need the patent ductus or the ductus arteriosus to supply the lungs to keep them alive. So from this critical, I'm going to speak about tetralogy of Fallot, which is the most important cyanotic and common cyanotic congenital heart disease. It accounts for 5 to 10% of all congenital heart disease. And as you know, the original description of tetralogy of Fallot is the 4 abnormalities, that is a large VSD, then the RVOT obstruction, right ventricular hypertrophy, and overriding of the aorta. Actually, these 4 abnormalities is in the actuality, only 2 abnormalities is needed to cause this tetralogy of Fallot. It's the large VSD to equalize the pressure and the RVOT obstruction. And as we are going to mention in the coming slides, in this patient, the pressure in the right and left is almost the same. How they manifest? This patient will manifest with cardiac murmur at birth, and the hypoxic spills usually come later. It will not show in the first few hours of life or in the neonatal period. The cyanosis and cyanotic spills usually come late. And the most presenting symptoms in this patient is murmur, and sometimes, occasionally, this patient might be asymptomatic. How you will find in physical examination, you will find this patient cyanosis, sometimes tachypneic. Clopping usually occur late in this patient if you find them in the late after the infantile period or early child. Then you might find in the examination RV taps due to RVH and systolic murmur. And you might find also the single second heart sound because the pulmonary component is too soft in this patient due to right ventricular outflow obstruction or severe infundibular spasm. So you might not hear the murmur. Radiography is very characteristic for this patient because you might find what we call the boot-shaped heart, which is a concave main pulmonary artery, and the RV will be upturned apex because of RVH, and so you will show the signs of boot-shaped heart, the X-ray. And as mentioned by Dr. Bashir, the lung will be oligemic because the right ventricular outflow tract is obstructed. So the lung will be oligemic because there is decreased blood supply to the lung. What's the natural history of this patient? If this patient is, if not treated, they will become more cyanotic, and they will develop polycythemia, hypoxic spills, and the chronic illness will cause growth retardation.
حسين الصوت
Is it clear now?
Yeah, it's clear. Go on. Move on.
Okay. So this patient, if not treated, they will develop hypoxic spill, gross retardation, brain abscess, subacute bacterial endocarditis, and coagulopathy. What we will see by ECG, we'll see right axis deviation and right ventricular hypertrophy. Due to right ventricular hypertrophy, we'll see right axis deviation. So these patients should be treated medically before surgical treatment, which is usually done at 4 to 6 months. And we need to treat the hypoxic spill. If there is a hypoxic spill, we have to treat the hypoxic. I'm going to speak about it in a minute. Then it is very important to educate the parent to recognize and treat the spills. If the parents, they have a patient with cyanotic spills or tetralogy of Fallot, it is very important to educate them about the tetralogy of Fallot and how to treat and how to manage the spills. Oral propranolol, we start them just waiting for surgery. Because it's not a treatment, just it is a palliation. This oral propranolol will decrease the heart rate, it's a beta blocker, and will decrease the RVOT spasm. Sometimes this patient might need what we call RVOT stent, which is done by cardiac cath. We need to keep the RVOT or right ventricular outflow tract patent. So we put a stent to keep the RVOT patent and promote the pulmonary blood flow to the lung. Also, we need to treat the iron deficiency anemia and to detect it early. And very important to know about hypoxic spill. This is an emergency and should be treated by a pediatrician. No need to call a cardiologist. You should know how to treat hypoxic spill and how to diagnose hypoxic spill. As we know, it is an urgent clinical situation, and every physician should know and understand the clinical manifestation and the correct management of a hypoxic spill. Okay, in this slide, I'm going to speak about the pathophysiology of hypoxic spill. Okay. As we know, in tetralogy of Fallot, we have a large VSD. So as we mentioned, the pressure in the right ventricle and left ventricle will be almost the same. As you see here, the pressure, the systolic pressure in the right ventricle and left ventricle is almost the same. What will make this tetralogy of Fallot going into spells? When the systemic vascular resistance decrease, okay? When the mechanism of tetralogy of Fallot or hypoxic spill in tetralogy of Fallot, the systemic vascular resistance will decrease and the RVOT spasm will increase. So the blood will shift from right to left. And eventually it will go to the aorta and to the systemic circulation and it will cause cyanosis. So this is the main mechanism of hypoxic spill. Because we need to know this mechanism, so then we can treat the hypoxic spill. Usually hypoxic spill occur after the infantile period, like it can start at 2 to 4. Although it can present early, but this is in certain patient who has like small pulmonary artery branches or severe TOF type, but usually it presents late. It has significant morbidity and we should treat it early because it might cause convulsion, cerebrovascular accident, and even it might cause death. So it's very important to treat the spills. And we need also to inform the surgeon. If you have cyanotic spills, the cardiac surgeon should know about the patient because this is an indication of surgical treatment. This is a mechanism, we spoke about it before. I'm going to read it in very quick. Because of the VSD, as we mentioned, in tetralogy of Fallot is large enough to equalize systolic pressure in both ventricle. So the RV and LV may be viewed as single chamber that eject blood to the systemic and pulmonary circulation. So either increase in the pulmonary resistance, I mean the right ventricular outflow obstruction, or decrease in systemic vascular resistance will increase the degree of right to left shunt, producing more severe arterial desaturation. This is a mechanism of a spill. This change in the SVR play a primary role in controlling the degree of right to left shunt. So how to treat this mechanism, or how to treat the tetralogy of Fallot? It is by increasing the systemic vascular resistance. So we give medication to increase the systemic vascular resistance so we can abolish the right to left shunt, or we give also medication to decrease the pulmonary vascular resistance at the same time. And how this happens? There is triggering factors. Triggering factor for this cyanotic spell, like tachycardia, hypovolemia. And so we need to treat these patients if they have tachycardia by slowing the heart rate. We have to give a volume to abolish the cyanotic spell. Clinical feature of hypoxic spill is severe cyanosis, hyperapnea. The patient might have rapid and deep respiration, worsening cyanosis. Sometimes if you auscultate, you will see the disappearance of the heart murmur. Why this murmur disappear? Because the RVOT will be very sparse and there is no blood going through the RVOT, so you will not hear a murmur. So as we mentioned, hypoxic spell is very serious disease and can lead to death. And treatment is by increasing, as we mentioned, increasing systemic vascular resistance. So we can abolish the right to left shunt and make the shunt from, instead of right to left, it will be left to right. And also we give medication to slow this or to decrease this RVOT obstruction or decrease the systemic pulmonary vascular resistance. So we can promote the blood to go to the pulmonary artery and the shunt will be from left to right. So to abolish this, we need to ask the mother to put the patient in knee-chest position. What is the mechanism of knee-to-chest position? This will increase the systemic vascular resistance. Knee-chest position will increase the systemic vascular resistance. And this is one of the main interventions that we need to do in the management of cyanotic spills. We can use also morphine. Morphine is used either subcutaneously and can be administered to suppress the respiratory center, so it can abolish the hyperapnea and break the vicious circle. Oxygen is controversial, but we can give the oxygen so as to decrease the pulmonary vascular resistance. We need to treat the acidosis. Acidosis can be treated by fluid. So if I have a patient with cyanotic spells, give a fluid. Don't be afraid of heart failure, because sometimes they mention this patient, they call us in the cardiology and they are telling we have patient of tetralogy of Fallot. How about the fluids? Every patient with tetralogy of Fallot, you can give fluids as much as you can. Because the lung is protected, this patient will not develop heart failure unless they have large collateral or something else. But in the tetralogy of Fallot with hypoxic spell, it is mandatory to give fluid. Give fluid as much as you can. Because fluid will treat the acidosis at the same time. The other option of treatment, we can give ketamine. And ketamine also will increase the systemic vascular resistance. We can give propranolol, and sometimes also we can give phenylephrine. And as we mentioned, one of the option of treatment is urgent PT shunt. Urgent surgical PT shunt is one of the option of the treatment. So if these all management fail, we can go to urgent correction or urgent aortopulmonary shunt. What we mean by aortopulmonary shunt or PT shunt, we create a shunt between the pulmonary and systemic. So the blood supply to the pulmonary will be directly from the systemic artery. Okay, now we finish with tetralogy of Fallot. We come to the systemic duct-dependent lesion, which is hypoplastic left heart syndrome and left obstructive lesion. Dr. Bashir also already spoke about these three, so I will speak only about hypoplastic left heart syndrome. So in hypoplastic left syndrome, there is the left ventricle is severely atretic or hypoplastic. This is the left ventricle, severely atretic or hypoplastic. The right ventricle here is dilated. And we have, this is the aorta or ascending aorta is either atretic or hypoplastic, and the mitral valve will be also either atretic or hypoplastic. So the left side is non-functioning. So instead of the left side taking the systemic, the right side will take both systemic and pulmonary artery circulation. We'll tackle all of this circulation. The right ventricle will receive the pulmonary venous flow, will receive the systemic venous flow, and will eject to the aorta and pulmonary at the same time. These patients, they need the foramen ovale or patent atrial septums to survive, because the left side is obstructed. So no ways for the blood to go to the systemic circulation unless they have ASD. So if these patients, they don't have ASD, we have to create ASD. So the blood will go to the right ventricle and be ejected to the systemic through the right ventricle. This hypoplastic also, there is other critical congenital heart disease as mentioned by Dr. Bashir. The critical aortic stenosis, and usually, as mentioned by Dr. Bashir, usually associated with bicuspid aortic valve. And this lesion can occur at any level of the aortic valve, either at the aortic or supra-aortic or subaortic valve. Coarctation, mentioned by Dr. Bashir, it is mandatory in this patient to have a ductus arteriosus. Although these patients, sometimes they might have a collateral and they might survive to other period, and they are not detected early in life. Interrupted aortic arch, there is 3 types, A, B, and C. And in this type, there is in this lesion, there is a discontinuation between the ascending transverse and descending aorta. This is the ascending aorta. This is a descending aorta. So instead of continuation, there is a discontinuation, and the lower part of the descending aorta is supplied by the ductus arteriosus. It is mandatory, as mentioned by Dr. Bashir, in this patient. They cannot survive if they don't have a shunt like a patent ductus. So we need to start them on prostaglandin A. I will pass this slide because this is an echo of patient of coarctation. I will pass it very quickly. This is the ascending aorta. This is a transverse arch, and you can see here this is a head and neck vessels. Okay. So the coarctation usually occur here. Okay. After the subclavian, if you can see here, there is a swirling jet. This is the area of coarctation for those who are, inshallah, بعد ما تنجحوا إن شاء الله وتجونا في cardiology. This is an echo of patient with coarctation. Again, this is also a patient with coarctation who has posterior, posterior shelf with acceleration, flow, and coarctation. This is a VSD, this is a right ventricle, left ventricle. This is a tricuspid valve. This is a mitral valve. This patient has ventricular septal defect. Sometimes patient with coarctation might have additional VSD. This is how it appeared in the CT scan, and Dr. Bashir is the pioneer of CT angio. They can elaborate more in this angio, but usually this is how it appears in the CT angio. This is the aorta, ascending aorta. This is the head and neck vessels. And this is the area of coarctation. You can see how this area is tied, and there is a post-stenotic dilatation. And usually these patients, they have collateral. They have collateral from subclavian or whatever. They are supplying the lower part of the body. This already mentioned by Dr. Bashir, it's the left side lesion. This patient will present with collapse and low cardiac output if the BDA close. And as mentioned by Dr. Bashir, BDA can close in the first week of life and even first few hours of life. BDA can close and this patient might present. The problem sometimes this BDA might persist, okay? Because we have what we call a functional closure of PDA and anatomical closure. So sometimes this PDA might persist and this patient might be discharged home and comes in the AR with collapse, and they are diagnosed as sepsis and metabolic disease, and they are treated lately. So every patient will come with like a picture like a sepsis or metabolic screen. We have to put in mind that this patient might have critical congenital heart disease, especially the left side lesion. It is important to mention that in severe coarctation, the clinical examination is very important. So when you are referring a patient to a cardiology, you have to check first the pulses in arm, especially the right arm, because you might find these patients have their lower extremities, the pulse might be weak, peripheral pulsation. And you might find also a high blood pressure. So this patient might present with peripheral pulsation, weak peripheral pulsation, and hypertension or systolic pressure gradient in the upper, which is higher than the lower limbs. So it's important to check the saturation, the peripheral pulsation in this patient, and to check the blood pressure in the upper and lower limbs. Very important to take history, CBC, arterial blood gas. This patient might have metabolic acidosis. We need to treat the acidosis before doing echo, and we need to stabilize the patient. These patients sometimes might present with electrolyte disturbance like hypocalcemia or hypoglycemia. We need to do chest X-ray, ECG, and echo. This is an X-ray of patient with severe coarctation of the aorta, and you can see how the left side is dilated and the pulmonary congestion and the cardiomegaly in this patient. Usually these patients, they have right ventricular hypertrophy because, as we mentioned, the right ventricle is the dominant ventricle in the neonatal period. So the ECG, you might see right ventricular hypertrophy instead of left ventricular hypertrophy. Usually LVH usually present late, but early you will see right ventricular hypertrophy. Management, as we mentioned, we have to correct the acidosis, start prostaglandin as early as possible. Sometimes we need to shift this patient to ICU to start inotropic support like dopamine or dobutamine. And occasionally they might need intubation. Ultimate management is surgical, as mentioned by Dr. Bashir, in both interruption and coarctation. And sometimes we can try balloon even in the coarctation of the aorta. We can try balloon dilatation if they come late. But if they fail the balloon dilatation, they need to be treated surgically. Critical aortic stenosis mentioned by Dr. Bashir, we can try a balloon dilatation. If not benefit, they can go for surgical treatment. Regarding hypoplast left heart syndrome, as we mentioned, hypoplast left heart syndrome can present with many various pictures, like atresia of the aortic and mitral valve, and hypoplasia or stenosis of the left side. And the left side usually is moderately or severely hypoplastic. They can present in the immediate neonatal period. And as we mentioned, the right ventricle maintains both pulmonary and systemic circulation via ductus arteriosus. So pulmonary venous blood passes through the ASD or patent foramen ovale and mixes with systemic venous flow. So there is a total mixed lesion, and this patient, as we mentioned, will present with cyanosis and heart failure. The clinical presentation is like the ductal dependent left side lesion. They present with poor systemic perfusion, signs of poor systemic perfusion and shock. The peripheral pulses may be weak, and this lesion usually associated with syndromes like Turner, trisomy 13 or 18, and they are usually associated with brain anomalies. So in every patient with hypoplastic left heart syndrome, it is mandatory to do at least brain ultrasound to exclude brain anomalies. Investigation is the same. We'll do history, physical exam, CPC. We'll do electrolytes, make sure that the blood urea is normal because the blood supply to the vital organs is compromised. So this patient might present with acute renal failure. We have to do chest X-ray. We might find cardiomegaly and congested lung. ABG is mandatory because you might find acidosis. And definitely we need to do ECG and echo. For a general pediatric, if we suspect a patient with critical congenital heart disease, either left or right side, it is mandatory to start prostaglandin. This will make a big difference in the treatment of this patient. I'm not going to speak about hypoplastic left heart syndrome in detail, but I want you to know about the mechanism of or pathophysiology of this Fontan, because you might face a patient in the ER with Fontan, and you need to know the concept of Fontan. As we mentioned, in those patients with hypoplastic left heart syndrome, the left side is non-functioning. Okay, so the left ventricle is either small or atretic. The mitral valve sometimes might be atretic. So we need some ASD or patent foramen ovale. So the blood will go from the left to right. So in these cases, the right ventricle is tackling all the blood supply to the lung and to the systemic circulation. So the concept of Fontan is to unload the right ventricle, because the right ventricle is pumping to, as we mentioned, to the lung and to the systemic circulation. So we do first the Glenn, we call it the Glenn procedure. This is either the first or second step of univentricular pathway. Usually we do it for the patient with either hypoplastic right or left heart syndrome, because Fontan might be done for patient with tricuspid atresia, left heart ambulance AVSD, hypoplastic left heart syndrome. So there is so many conditions that need to be go in the line of univentricular heart. So in this patient, either if we have left side or right side hypoplast, here in the hypoplastic left heart syndrome, the right ventricle will take the responsibility of ejecting blood to the right and left, as we mentioned. So in order to unload the right ventricle, so we'll take first the superior vena cava and connect to the lung. So now the superior vena cava in the Glenn procedure, is connected to the pulmonary. So the blood, unoxygenated blood, will go directly to the lung and being oxygenated and come back to the pulmonary vein. So this is the first step or second step of Fontan. And the final step is what we call a Fontan procedure. In Fontan procedure, we take the inferior vena cava and connect directly to the pulmonary artery. So now we unload the right ventricle, we take the systemic venous blood and we connect it directly to the pulmonary artery. So the blood will go, the unoxygenated blood will go to the pulmonary artery and being oxygenated and come back to the left side and go to the right ventricle, and from the right ventricle goes to the systemic. So now the right ventricle is taking only the responsibility of ejecting blood to the systemic circulation. So this is the idea of Fontan. The idea of Fontan to unload the right ventricle, because if this right ventricle, if unloaded, it will fail very soon. Now we finish from the hypoplast, we'll come to complete transposition of the great arteries, which is important topic. We have to know about it in the pediatric cardiology or general pediatric. This is the most common cyanotic congenital heart disease presenting in the newborn. As we mentioned, tetralogy of Fallot might not present in the neonatal period unless it is a severe type, but TGA, especially TGA with intact septum, they present early in life. So it is the most common presenting in newborn, okay? But the most common cyanotic congenital heart disease is tetralogy of Fallot, okay? TGA comprise about 5% of all congenital heart disease. And as we know, in these conditions, the aorta arises from the right ventricle. Instead of the aorta arising from the left, the aorta coming from the right and the pulmonary artery arises from the left ventricle. So this we call it duct-dependent mixing lesion, because this patient also, they need the duct to be patent. They need a patent ductus arteriosus for survival. So we call it ductal dependent, but the duct dependent here is for mixing. And we are going to explain this in a minute. Okay, this is a normal heart where the superior and inferior vena cava connected to the right atrium, and then through the tricuspid valve to the right ventricle, and the right ventricle is connected to the pulmonary artery, while the left ventricle is connected to the aorta. So the unoxygenated blood in the right side will go to the lung and being oxygenated and come back to the left ventricle and ejected to the systemic. While here in transposition, the aorta, which carries the blood to the systemic, is connected to the right ventricle. So the unoxygenated blood, instead of going here to the pulmonary artery and being oxygenated, it will go directly to the systemic circulation. And from the systemic circulation, it comes back to the IVC and SVC. So there is a separate circle of the unoxygenated blood here and separate circle for the oxygenated blood, because the oxygenated blood, it will be pumped to the lung through the pulmonary artery, and instead of being pumped to the aorta, the oxygenated blood will go to the pulmonary artery, and then it will go to the lung and come back through the pulmonary arteries. So we have two separate circles. So we call it, instead of the circle coming in series, it is a parallel circle. So this one circle and this is a one circle. So we need a mixing of blood. In TGA, we need a mixing. So we need either a BDA or ASD or VSD for survival. Otherwise, this patient will not survive. This is, we call it simple TGA when we have a TGA with intact ventricular septum. So the aorta, as we mentioned, is carrying the blood from the right ventricle, while the pulmonary is carrying from the left ventricle. And we have only what we call PFO and PDA. These patients usually present early in life with severe cyanosis and sometimes heart failure, and they need intervention early. We have other types of TGA, like a TGA with VSD. This patient might present late and might not be diagnosed early. They have some sort of cyanosis, but sometimes they might present late. As we mentioned in TGA, we need to have a communication. So this patient has TGA, but he has also an atrial communication. This is mandatory for life because, as we mentioned, there is two separate circulation, the right side circulation and the left side circulation. So we need to mix the blood. So the blood from the oxygenated blood will come from the left side to the right side and supply the aorta to the RV. So in this patient, we need to have ASD. If no ASD, I mean, if the ventricular septum or atrial septum is intact, we need to create an atrial septal defect. As we mentioned, this patient will present with desaturation, and therefore the tissue, including vital organ, such as brain and heart, are perfused by a blood which is low oxygen saturation, because the aorta is carrying from the right ventricle, which has oxygen saturation low. So the brain definitely will have a low oxygen saturation. While the well oxygenated blood will go to the left area, to the left atrium, and comes back to the pulmonary artery and then to the left atrium again. So there is two parallel circulation. And as we mentioned, in this patient, we need to have a communication. This patient, they have severe cyanosis at birth, to the extent of sometimes saturation might reach down to 30 and 50%. They have severe metabolic acidosis due to anaerobic glycolysis. So we need to have start them in prostaglandin as early as we can. So we need to take a history in this patient, do physical examination. Usually these patients, they are large male, in male, and usually they are chubby baby. They have single heart sound. If you listen to their cardiac auscultation, you will find S2 is single, because
Hussein, your connection, we are not hearing you. Dr. Hussein. Hello. Hello.
Dr. Hussein is the connection. I think Dr. Hussein, the connection is not he's not connected now. However, this is very informative. Yeah, just call him Dr. Abdullah.
محمد حسن.
This is very informative.
أنا هتصل على هبة زوجته وأكلمه. اتكلم معاهم أنت تتكلم معاهم.
خلاص.
Okay.
Okay. This is very informative talk and great discussion. While Dr. Hussein will be back, we will just mention some comments here and some questions regarding people asking about the difference between the DTGA and the LTGA. The DTGA, it means that there is an atrioventricular concordance and ventricular arterial discordance. And what is the meaning of that? It means that the blood which is come from the lungs to the left atrium, it will go to the left ventricle. However, it will go back to the lungs through the pulmonary artery. While the blood coming from the SVC and IVC and going to the right atrium, going to the right ventricle, then it will go through the aorta instead of going through the pulmonary to go to the lungs to take and oxygen saturation. This is the DTGA, while the LTGA, or the other name called CCTGA, or the congenitally corrected transposition of the great arteries. In this one, the patient will come pink. Why pink? Because the blood which is come from the pulmonary vein to the left atrium, it will goes to the right ventricle. And then from the right ventricle, it will goes to the aorta. And the other coming through the IVC and SVC to the right atrium, and then going to the left ventricle instead of going to the right ventricle, it will go through the pulmonary artery to the lung to get an oxygenation. So in the LTGA or CCTGA, because there is a double discordance, this is lead to a physiological correction of the situation. I think Hussein Abdo is back. Okay. So this is the difference between the DTGA and LTGA. Until Dr. Hussein will come back, we will continue just answering some of the questions. Any news, Abdullah?
Hussein coming back, there is a question which is repeated many times about IV propranolol. Can you speak about that? IV propranolol in TET-spell, tetralogy fourth spell.
Okay, you can go ahead, Abdullah. Go ahead.
Okay, so IV propranolol is not totally contraindicated. Should be used with very high cautions, because IV propranolol can cause sudden death if the patient has, heart block, any kind of heart block. IV propranolol can cause fatal arrhythmia and can cause death. Also, we don't know if the patient background, if the patient has bronchial asthma, bronchospasm, heart failure. This all is contraindicated the use of IV propranolol, because if you give IV propranolol and patient collapse, there is no way to regain the patient back. I have experience in my hand. The baby will give him IV propranolol and he arrested and we couldn't regain him back. That is why people in books, in all books, it's not written as contraindicated to give. You can give with caution, but usually we are using oral propranolol because the release is slow and it will not cause the major side effect or cardiac collapse as IV propranolol. Thank you.
Okay, so we will follow the safety measures as Dr. Abdullah mentioned. And Dr. Abdullah, as we know, he is the expert in the cardiology and NICU and ICU bar. For that reason, any question like that, he will tackle it. Welcome back, Dr. Hussein, for continuation of this great talk. Kindly, can you carry on?
Thank you very much. It seems that I have a technical problem. If you can give me like 2 or 3 minutes, then I can fix this technical problem and come back to you.
Okay, you can do that. What in the meantime, we can tackle the questions in the chat.
Again, Muhammad, another person asked about TGA, DTGA, and LTGA. Don't confuse yourself. This is a TGA. When you said TGA, that means we mean the DTGA. If they said LTGA, that is the corrected TGA, congenital corrected, physiologically normal. So it is the other name is ventricular inversion. That the ventricle is inverted. So the physiology is like that. The pulmonary veins is draining in the left atrium, and the SVC, the systemic vein, which is superior vena cava and inferior vena cava, is draining to the right atrium. Okay, so this is by default. If the left atrium drained to the left ventricle, and then the left ventricle eject to the pulmonary instead of the aorta, this is the DTGA. Okay, the LTGA, the pulmonary veins drain to the left atrium. The left atrium, instead of draining to the left ventricle, it drains to the right ventricle. So the ventricle is twisted. Okay, and then the right ventricle will eject to the pulmonary. So physiologically, there is no cyanosis because the ventricle, the left atrium drain to the right ventricle, and the right ventricle eject to the aorta. So it is corrected physiologically. This is the LTGA, while DTGA is cyanotic case immediately after birth, and that is a critical one. So don't confuse yourself between DTJ and LTJ. If it mentioned TGA, that means it's DTJ. But if it mentions CCTGA, this is LTGA, which is congenitally corrected TGA. That means physiologically corrected, because the oxygenated blood going from the left side to the right ventricle to the left side again to the aorta.
Okay, just in the same page, what Dr. Abdullah mentioning, and just I explained before, and Dr. Hussein showed very nice and beautiful diagram before for the heart. To differentiate between the DTGA, LTGA, and other lesion, you need to know the normal anatomy, and this is explained in a very beautiful way by Dr. Hussein and Dr. Bashir. This is the normal heart. Usually in the normal heart, you will see the pulmonary veins connected to the left atrium, if you are seeing the diagram here. And this one is the left ventricle receiving this oxygenated blood coming from the left atrium. This is normally, it will go through the aorta. In the cases of DTGA, this oxygenated blood, it will go to the pulmonary, not to the aorta. So this will let the circulation come from the lung and goes back to the lung. So as you are taking from al-bahr lil-bahr, you are taking the same oxygenated blood and returning back to the lung. In such a case of the detransposition of the great arteries, you will see a cyanotic child. This is the most important part for the general pediatrician. While in the CCTGA or LTGA, because the ventricle itself are inverted in position, so whenever there is an oxygenated blood coming from the left atrium to the right ventricle, it will goes to the aorta. For that reason, the child will be pink. This is again the most important part for the general pediatrician. And in such a case, you will see the child sometimes without symptoms, and you cannot notice even this child has an lesion, except if there is an VSD or the patient with heart block in some cases. Hussein, are you back? Okay, while Hussein is not here, we will take some question to tackle them. Do you have any comment, Bashir? Are you hearing us, Bashir?
Just one comment. We have to differentiate in acute setting that the patient, we have to differentiate. This patient is, unit came as cardiac. Is this patient cyanotic category or obstructive category? Okay, cyanotic category, that means the right side heart is obstructed, which is the pulmonary. Either we have tricuspid atresia or pulmonary atresia or severe pulmonary stenosis, sometimes tough. In the left sided category, that means either we have critical aortic stenosis, severe coarc, or aortic atresia or mitral atresia. So this is the difference. Dr. Hussein is back. Maybe we'll go more with Dr. Hussein now. Thank you for your patience.
Thank you very much. Sorry for this technical problem. We resume our presentation. So as we mentioned, history is very important in this patient of TGA. As we mentioned, they are male and large patient. They have single second heart sound. They present with severe hypoxemia, and sometimes they might have hypoglycemia. ECG will show right ventricular hypertrophy, and sometimes you might find biventricular hypertrophy if they have a large VSD and BDA, and the pulmonary vascular system is congested. So the left side will be dilated, and you might show left heart dilatation at the same time and left ventricular hypertrophy. Radiography is very characteristic, as you know. In TGA, we have what we call it agon side. Because we have narrow mediastinum. Why we have narrow mediastinum? Because the aorta is overlapping the pulmonary artery. So you will show a narrow mediastinum, and you will see the heart like an egg on side. Management is very important to stabilize this patient before surgical procedure. Sometimes this patient might need emergent cardiac catheterization to open the atrial septal defect or to create an atrial septal defect. We need to treat the electrolyte disturbance like hypoglycemia, hypocalcemia. Very important and very vital is to start prostaglandin in this patient. Oxygen is controversial because it lowers the pulmonary vascular resistance, and sometimes it might increase the pulmonary congestion. But if needed, we have to start prostaglandin, and it is mandatory for this patient before surgery. If they are not stable, is to do balloon atrial septostomy to create an adequate interatrial communication. Surgical, now we are doing what we call arterial switch operation. We switch the aorta to the normal side and the pulmonary to the left side, to the right side. So we correct the transposition of the great arteries. Early, they are using what we call it the physiological correction. We call it sealing and master and other type of operation. This is my references. وتمنياتي لكم بالتوفيق والنجاح. Thank you very much. This is the end of my lecture.